Hello, everybody, and most welcome to White and our webinar today. Health is a human right and an important driving force for social and economic development. There is, however, a long way to go in removing stigma around mental health. My name is Monica from Schmalensee. I'm the former CEO of White Arkitekter, and I'm also one of the MDAs, Major Design Advocates for the Mayor of London, Sadiq Khan. For me, architecture is a lot about making what architecture can make, not just the facades, what it's looked like. So I think the title of today's webinar is very encouraging. Destigmatizing mental health through architecture. Today, I have the honor to moderate this webinar. It will be recorded, so you know that. Our chat will be open during the webinar, and please use that for comments so we can see what you think about it and we could use that afterwards. There will also be a Q&A at the end of the session and hopefully a lot of time so we can have some discussions to our speakers and you can ask those questions. And if we are running out of time, we will get back to you after the seminar with some comments on and some answers. So, especially now with the pandemic, we also know that mental health problems are one of our major illnesses of our time. And yet there is a stigma around mental health, and that we would like to discuss that, why we need to rethink and redefine the design of today's mental health buildings to create more safe, secure, and attractive environments. We will listen to a panel of experts, how and why participatory design is needed, and our speakers will focus on the design of a new generation psychiatric facilities, both in the UK and in Sweden. The discussion will explore the role of design in increasing the effectiveness of mental health facilities for the wider benefit of society. I hope also to learn a lot, of course, about how healthcare differs between the UK and Sweden, but also how we can learn from research and academy. But most of all, it's interesting to listen to the engagement and commitment for those working with these kind of projects. And that's why we have this very nice panel today. And our speakers today will be Dr. Evangelia Chrysikou, Assistant Professor at the Bartlett Real Estate Institute, UCLA, Program Director of MSc Healthcare Facilities and Architect specializing in medicine. Followed by Cristiana Caira, Senior Partner at White Arkitekter, Artistic Professor at Healthcare Architecture at Chalmers University in Sweden. Malcolm McFrederick, St. Pancras, Transformation Program Director at Camden and Islington NHS Foundation Trust. For White, this has been, healthcare has always been a very important for our projects. Stefan Lundin, who is a senior partner at WISE, has also specialized in architecture for mental health. He's also editor of a book called Architecture as Medicine. The importance of architecture for treatments when it comes to psychiatry. As head architect for Östra Hospital, Stefan has been awarded Forum Healthcare Award. But today we will start out with a pre-recorded film that Stefan will interview one of the service users, Jan de Vir Lernbring at Östra Hospital Acute Psychiatry Ward. So please, can we now look at the film?
Welcome to the Clinic of Psychiatry at Östra in Gothenburg. I'm sitting here with Jan de Vir Lernbring. John, very welcome. And thank you for joining us today. Could you start by tell us a little bit about your story?
I've been a patient since I was 16 years old. And I have been addicted to drugs and alcohol since I was 16 years old. It has been a hard journey in my life, and I'm still a patient. And today I have lectures and workshops and meeting with patients and staff in the psychiatric care, and I also meet doctors who are going to be psychiatrists. So yeah, That's
Yeah.
that's a bit of my life.
A bit of your life, yeah. But during those 4 decades, is it the same to be a patient today and when you was just a teenager 40 years ago?
The stigma have changed enormously. When I was a kid, nobody knows what was the problem with me, only that I was a bad kid. Today I have 5 neuropsychiatric diagnoses, such as ADHD, Tourette syndrome, GAD, which is an anxiety syndrome. I have PTSD and Asperger, all those 5. When I say this to normal people today, nobody judge me anymore for that, because it's have been more common. Everybody knows someone who has something.
If there have been a change on the view on psychiatric disorders, could you see some kind of the same difference when it comes to buildings for psychiatric disorders? I mean, you've been to several of these institutions.
Yeah.
Could you see a change there as well?
If I go in this building, which is like a diamond in if I compare it to the old place, Lillhagen, Lillhagen was the maniac house. Okay. And no, we didn't want to go there. And go here is like going to an ordinary hospital. Yeah. Only you go here with your soul or your mental health. Yeah. So it's a big difference.
Coming back to Lillhagen, what actually made that? You call it the maniac house. How come? Why?
I would say the location is number one, because if you're heading for Lillhagen, the maniac house, it was only that house. So you had to be a maniac to go there. Yeah. And the reputation and the stigma around the name Lillhagen had been for many years. At that time, it was more of a stigma to have those disorders, and it was a rougher environment, both between patient and also between staff and patient. But I think that they maybe did their best, and it was another time. So the location is very important. Yeah, because when you go here, it's the same. Someone go there with the knee, I go here with my mental neuropsychiatric disorder to my doctor, and he goes with the knees. We go to the same area.
And that's important for you as a...
It's a signal for whole society, because we have to learn to live side by side.
As an architect, you have your own idea, you come from a special culture, and maybe you think you know what's important. But from your perspective, as a patient and as you personally, what is do you find interesting or good when it comes to the physical environment within the wards?
I have been here a lot in this building, and I would say what I appreciate most of it, if I compare to other places and to the old place, it's the light. It's much windows, so the walls are light. The other thing is, when you come in, it's like you're coming home to a warm feeling. It's a wooden floor, it's flowers, it's colors, it's like a living room area, it's like the TV room area, it's like the kitchen area. It's a little bit of a feeling cozy, safe at home. And the third thing, maybe this is the most positive, and that's the garden yards. To be able to go out and be in nature. Everybody knows that nature heals. And walk around a little bit, and green bushes and flowers. And so that's the top 3.
But I guess you have 1 or 2 negative remarks as well.
I have more than 1 and 2.
You
but
have?
This is a diamond, a rough diamond in my eyes. But everything can be a little better. So here come the things I had done a little bit different. The reception, when you come in the building, there is no reception with people. There's only a big room, and you are in anxiety, or you are in half psychotic, and you have to read in small notes where you're going. The feeling should be when you come into this psychiatric building, now you are safe.
Yeah.
You're in a safe house.
Yeah.
That's the first thing. The other thing I don't like so much is we have one long corridor, and everybody goes through that corridor. Patients and staff and young people come there, visitors come there. Many times we have lived hard lives and we have done maybe some stupid things. And to meet an enemy in a long corridor, even if enemies often is mostly in head, and you see someone is coming a long way in the corridor, you know, who is that? Is it someone I have cheated sometime, or is it going to be a conflict? So long corridors, I don't like it. The wards are, in most cases, very good. It's like coming home, like I said. I don't know in the rest of the world, but in Sweden, we mix men and women, and we mix they who are here by force and they who are here by free will.
Yeah.
And in those two wards, the overview should be a little bit better, and the blind spots should be eliminated. Yeah. Because we don't like men who have a sexual disorder sneaking into another patient, and we cannot lock the doors. So I think the staff and the patient also wants to know that the staff can see us at all times. Yeah. So they have three things to cut the diamond to perfection. Yeah.
What would you say to the architect? What is the most important thing as an architect, and when it comes to the architectural design, to consider when you're doing a new facility for psychiatric disorders?
I think what you mentioned before, that the architecture could be a bit of the medicine. If 10 days of care could be 7 days of care, because everything was optimum for the patient and the staff. Yeah. And they're calm and they feel secure and safe and everything. How much money is that? 30% cut the time a patient have to be at the ward. Yeah. It's a lot of money, and it's a lot of suffering who goes away. Yeah.
What would you bring on to the next generation of planners, management, staff, architects? So we'll start a process for design and planning a new facility.
We have almost said everything, but what I want to say is that the heart and the will to do good and help people is the ground.
Stefan and Jan, for this film and your thoughts and insight. I think this is a fantastic film to start this, as I said before, this webinar with. Next speaker will be Cristiana Caira, senior partner at White, and Cristiana's work is very much focused on increasing collaboration between practice, research, and education. And Cristiana has led major healthcare projects, both in Sweden, but also international. And one of her latest international projects is the award-winning extension of the Panzi Hospital in Congo, in collaboration with the 2018 Nobel Peace Prize laureate, Dr. McFrederick. But Cristiana is also part of an expert international team recently appointed to draw up plans for Cambridge Children's Hospital. This hospital will be a brand new state-of-the-art hospital designed to take care of the whole child. Today, Cristiana will focus on how to rethink and redesign, and she will talk about the need of research and evidence during the project, but also the need to dare to innovate and to find and test new ways. And of course, to listen to the patients all the way. And one question will be, of course, do you have to separate mental health need to somatic care? And Cambridge Children is the first place where this kind of a holistic care model is the main vision for the project. So please, Cristiana, go ahead, and we will listen to you now.
Thank you very much, Monica. I'm going to share my screen now. Please confirm that it is in full screen. So thank you very much for your introduction. I'm going to present the psychiatric clinic in Borås today. The project started in 2011 with an architectural competition, and we have been working with the project since then. The first patients moved in October, November last year. The intention of the project was to create a welcoming center for psychiatric care with a human-centric design approach that responds to a patient-centered model of care. This is described by the client with a strategic vision document that was written at the beginning of the project, where there were very clear intentions and ambitions when it comes to the built environment, how it should look like and feel like both for patients and staff. I usually describe the process as a continuous and dynamic design process where we take help of evidence, best practice, policies, and reports, as well as we integrate it with the continuous dialogue with many stakeholders to make all voices be heard. At the beginning of the project, the Östra clinic that we just saw on the film had been completed, and there were knowledge on how the building and the architecture might have affected the outcomes in psychiatry. At that time, Stefan started his research at the Center for Healthcare Architecture at the University of Chalmers, where I also work today. And one of the research made together with Professor Roger Ulrich resulted into this paper that describes a theory on how the design of psychiatric wards affect stress and aggression by patients. Some of the most important factors are design of single patient rooms, access to daylight and green environment, and also design of generous day room with flexible use over time. It was an architectural competition, so we didn't have access to users and the client at the beginning. So we arranged our own sessions, inviting patients from different patient organizations and professionals to discuss together the qualities of the mental health care environment of the future. And we defined 6 main design strategies. These design principles have been kept during the whole length of the project, where the building has changed shape and size many times. But we always kept on this as leading stars for the design. The most important is destigmatizing by normalizing and by architecture. And this starts already on how we shaped the building and we located it on site and how we shaped the entrance hall to the building, but also in the later stages about the detail of many different solutions. Another important element was to work avoiding long corridors and monotonous atmosphere or an institutional feel. So we were really encouraged to work with small scale and variation. The healing environment, working with warm and cozy, homely materials, daylight and access to greenery, both visually but also physical, was important. At the same time, the balance between safety and healing has maybe been a major challenge in this project. And we decided together with our client that when it would be a conflict between healing and safety, the healing would always come first. The process has been continuous. It has run over years. We have been laying back on research all the time, looking for answers when we have difficult questions about shaping the building, but also co-designing, doing study trips with large user groups and building mock-ups, because sometimes it's difficult to discuss just on drawings and you need to test things in the real life. So how does it look like actually? As Jan says in the film, the most important element is the location, not to put the mental health somewhere else, but to put it just as everything else within a hospital campus. The clinic is composed by 3 buildings, a new star building, which will be the inpatient care, a new entrance hall, and an old building, the L-shaped, that will be renovated for the outpatient care. The entrance hall is not only the entrance hall to the psychiatric clinic, but it's also the second main entrance to the hospital, leading all staff and visitors down to the main conference center and restaurant of the hospital. We placed also, together with the client, all educational facilities of nursing students and teachers and doctor students within the main entrance hall. So that the entrance hall will be populated by visitors and staff and students and teachers and patients and relatives as a normal public place to meet. It was very important to have a personal reception, as Jan said, that had been a challenge in the project at Östra. So you feel when you enter the building that there's someone there taking care of you. We have built the entrance hall with a timber construction and with a lot of wood that gives a feeling of an atmosphere of a public, but also warm feeling of a building, and also a lot of effort on orientation and daylight. The Star building has a central elevator and staircase to enable a easier orientation within the building, and this glass box that was planned mainly for safety reasons through the work of Danish artist Ruth Kampau has become a fantastic piece of work called All the Colors You Are, which means you are allowed to be here in the building as you are every day. It is a very nice symbol of the empathy within this building. Why the shape of a star? It comes also from an exercise of co-design together with the staff. The wish was to split up the inpatient wards in smaller units. So the 18 single bedrooms are disposed in 3 wings of 6 patient rooms each, with a central entrance and day room in the middle. And 2 wards on the same floor to share facilities, but also staff. Grouped as a star around the logistic hub gives the shape of the building, which is articulated in small scale and bring in daylight in the nature straight in the heart of the building. Here you see a zoom in on a plan floor where you see from the main staircase you enter the day room, which is this generous room, and from there you can reach the wings that are composed by 6 identical patient rooms with a smaller day room at the end of the corridor with a balcony. So this is a photo of one of the day rooms with the courtyard just right outside. And we have managed to use wood in this project quite a lot up into the clinical areas in the patient rooms. And this gives an atmosphere of a non-clinical feel that was very important to work with. The patient rooms are the patient's own oasis, where to draw back and to be alone, where you don't feel like socializing. In this room, the balance between safety and a healing architecture that supports autonomy has been a difficult balance. And most of all, the small balconies that gives the opportunity to feel the temperature outside and the fresh air, even when you are not in the mood of going down to the courtyard, has been a difficult technical solution to solve. The building is almost completed. The Star building and entrance hall are complete, and the old building is under renovation this year. During the inauguration speech, the hospital director said that he feels a great sense of joy every time he enters the building. And this is maybe something of the most beautiful feedback we could have received as architects. What is the next step? Of course, we hope the building will be completed this year. And after the pandemic, we really hope to be able to go back and understand what we have done well and what we could have done even better. I think it is important in each project to use the knowledge collected by research and best practice as much as possible, but it's also important to plan to produce new knowledge through each project so that the next time will be even better. I thank you very much for your time, and I'm finished with my presentation.
Thank you so much, Cristiana, and it's so nice to see your images and pictures now from this completed hospital, because I remember when we won this competition, it was so fantastic. Anyway, I have one question though. When you talk about this, was it hard to find that for the clients to support your ideas regarding the design during the process, or how did you work with that? If you can just give me a short answer to that.
I think in this project, we started to talk about architecture from day one, since it was an architecture competition and we were chosen for the design that we had proposed. The client has had during the project the same high ambitions as we have, or even more. So we have never had really a conflict when it comes to the level of ambition. But it has been a very complex program and a very complex solutions that haven't been done anywhere else, like the balcony, for example, or using wood in the interiors in clinical areas is not done anywhere else in this size, in this scale. So sometimes it was difficult when we come to the point to say it costs more. What is the effect of it? Is it measured somewhere else? Are we sure that this wood wall would make such an effect on patients that is worth it compared to a painted wall in a warm color? And since it is not done anywhere else, it has been a challenge, and we had to, but we relied on each other. We had a very long and very good collaboration with our clients, and I don't think we really had conflicts more than we tested things that weren't done anywhere else. And then you have to be a bit brave about that.
Thank you, Cristiana. I think so. You dare to do something, and you need, of course, knowledge behind you, as we have as architects. But now I will turn over to our next speaker, Dr. Evangelia Chrysikou, who is, as I said before, lecturer at the Bartlett Real Estate Institute. And she is also a member of many important commissions in many countries. And she has also authored the books, Architecture for Psychiatric Environments and Therapeutic Spaces, and another one called The Social Invisibility of Mental Health Facilities. So this is research, of course. But today, Leah will discuss how psychosocial intervenience, this is a long word for me to pronounce really, and approaches can improve the lives of those with psychiatric needs. And Leah will also argue the importance of the dialogue between stakeholders and patients in the early design process to develop innovative solutions for psychiatric buildings. Please, Leah, go ahead with your presentation.
Allow me to share my screen. Hello, everybody, and it's a pleasure being here. I think I need to do that, and then I need to do that. I hope you can see my screen. Just a small correction. I'm in the UCL, University College London, not in UCLA. And the topic is about buildings as societal artifacts, and how this presentation started. Actually, this is what I have been doing about 20 years for mental health. I'm looking for evidence. But because we discuss stigma, I want to discuss how how people see stigma differently, exactly as our first presenter in the video said. And here we had a project that we looked how mental health buildings are compared to healthcare buildings. And we saw things like that, very similar architectural features, very different approach. So a lot of stigma, no stigma. And then when St. Pancras Hospital redeveloped their project, we did a consultancy for them on how they could implement international practice. And in that, we have a very extensive research with literature and a lot of case studies, international experts, we used my theory, the SCP model, which is a theory of how we evaluate psychiatric environments, and it's applicable in any psychiatric context in order to assess the results. We looked at examples across the globe, and of course, many different topics. And we looked at different aspects of how we can engage groups, things about provision, the location, which is very important, where do you put a building, the exterior, the layout of the buildings and all the subgroups that it contains, the interior design, the details, and what about older people in psychiatric buildings, which is a very new topic, very new topic. So, and we wanted to see from our examples, what was patient-focused now, what was out of the box, what had challenging aesthetics and design with innovation. And we found examples that I don't say that I agree with them. And this is my key message, that mental health architecture has moved to a new area where evidence does not always matter. And it's more about experimentation, which is good for stigma, not necessarily good for everything else, but definitely it's good for stigma. And I give you examples like this building that you can see the progress of the patient in the facade. We can see examples like goodie bags that the former patient could prepare with the help of the staff for the new person taking over the room. We could see exercise spaces in mental health facilities. And for me, this is amazing because it's necessary and it has been considered too dangerous for many years. And actually this project that I like because this is the facility. This is not a garden. This is not a garden of a mental health hospital. And this is not, I mean, this is the facility, an open facility for people with mental illness where people can try different things and exercise and socialize. And for me, that's amazing. The building is not there and that's wonderful. And another example from Italy that for me, the question is, what about anti-ligature and how safe is that? But the Italian colleagues, they decided that this is what they want. And of course, it might not fit my model. It might be considered too dangerous if you don't have enough staff, but it's a new approach. I don't agree, but it's there. And an example from the US, where new mental health facilities look like malls. This is completely non-stigmatizing. Malls have a special importance for Americans. And again, you agree or you don't agree, many points to discuss here, but it's a new approach. And so one of my favorites, that's a shop in the most expensive area of Ljubljana, one of the most expensive places to rent. And that's a project, a gift shop operated by mentally ill people. And at the same time, it's a helpline operated by mentally ill people from their till. And for me, that's wonderful because location is one important aspect, and going in the most expensive building of your capital and doing something amazing, it's something unthinkable. And of course, here I bring Malcolm's favorite example, and that's a boat in Paris, which is a mental health facility. It's a day center, and it's wonderful how it can be floating, and nobody thinks that we cannot have mental health on a boat on the most expensive area of Paris, which is the river, and actually exactly like the floating romantic boats that the Parisians have for the tourists, but it's a new approach. I said, not necessarily agree, maybe like it, maybe not, but it's a new approach and it doesn't have stigma. And of course, something I want to clarify, this is not evidence-based. And for me, that's very important to know.
Thank you, Leah. So I hope we will be able to kind of share your presentation afterwards, because it's so interesting to understand more about your toolbox. And if I get this right, as you show this toolbox, is that something that could be used for all kinds of projects, or do we kind of pick up some of those tools depending on what's most important, or how can it be used both, I mean, for public clients and others? That's so interesting to understand.
For the model, the research model, yes, I think it's very applicable. I mean, I have a lot of publications describing the model. I mean, whoever wants, I can explain in person at some point, but yes, it's applicable for all mental health facilities because it's, you can manipulate. I mean, it's a very important dialogue to see where you want to go. So you decide how safe a building should be. Not all buildings should be as safe. I mean, like a day center, for example, with a forensic facility have different safety requirements, and the same, the competence of the patients, for example, it's not the same. It depends on their trajectory and the personalization and choice. Of course, you can have a choice in a protected apartment. You should have a lot of choice. As I said, in forensics, some things should not be allowed because we also need to consider all three parameters. So that's basically the model, but it provides a dialogue and it has a lot of complexity to allow people to think and reflect in a patient and staff dialogue with the architects where they want to go and what is important for them. Because for me, that's important. The case studies that I showed are inspiring. They are not stigmatizing, but they are not there for everybody and they are not suitable for everybody. But it's just an indication that we change.
Yeah, I think, and even so, when I saw, I mean, parts of your buildings, it was kind of, you know, sharp angles and glass and all those things that one normally think couldn't be applicable or be used in these kind of hospitals. So that's really interesting what it gives and what it takes, and also the process, of course, during that. So,
and
well,
it's also the system. It's also the system. Maybe they have a lot of staff in that system and maybe they can afford it. Maybe they have patients that are more well. I mean, you can never judge by an image.
Yeah. Thank you very much, Leah. And we are getting back to you with more questions in the panel. But meanwhile, we are then going to hear from Malcolm McFrederick, who is then working for St. Pancras Transformation Program. And he is the director of Camden and Islington NHS Foundation Trust. And Malcolm has a long history of working in the NHS, which we have heard a lot about during the pandemic, of course, also what that is. And his operational expertise allows him to lead on service design and functionality, as well as on the development of environments for high quality care and patient experience. He has also been a chief operating officer in both physical acute and mental health trusts. So Malcolm's perspective is in the densely populated urban environment, many health facilities appear foreboding and very unfriendly. Malcolm will argue that mental health buildings need to cut through stigma to break down boundaries of public perception. What would acute mental health patient facilities look like if they were situated as normal feature of the urban landscape surrounded by shops, houses, and schools? Please, Malcolm.
Okay, thanks, Monica. Hello, everyone. My name is Malcolm McFrederick. I work for Camden and Islington NHS Foundation Trust. It's a mental health trust in the centre of London. And what I'm going to talk about now is how, after we received Leah's report on all the ways across the world that people have looked at destigmatizing mental health, we've used it in one particular building out of about the 7 which are in our programme. The thing you need to know about us is that we are a central London trust. We work in Camden and Islington, and if you know St Pancras Station, ever arrived there, or Euston Station, or King's Cross Station, that's where we are. Islington is the densest populated borough in London. So that's where the difficulty is for us, is finding space. What I want to do is suggest to you that if I live in South Camden at the moment, and I go to my general practitioner, and I have a physical health condition, say a cardiac condition that needs a consultant, this is where I get sent. Here you go. This is University College London Hospital. It's a fantastic facility. And if I look at that, I feel I'm going in to be treated well. I'm respected in my needs. If, on the other hand, I have a mental health issue that needs secondary care and I need to go to a consultant psychiatrist, this is where I get sent. And my contention is that if you get sent to one of these places, you do not get the same confidence, welcome as you do as if you go into physical health. And so what we want to do is turn from this sort of view into the same feeling that you get if you have physical health issues. And the building that I want to talk about is this current facility.
It's an inpatient unit. Oddly enough, it was the last leprosy ward in the whole of the United Kingdom. But if you have a look at it, just look at that boundary wall at the bottom. Look at the way that it says keep out. Look at the way it says not here, thank you very much. And that's our current facility. In addition, it's badly laid out. There is no fresh air for folk. There's no en-suites for the majority of people there. And that's not a good place to go into mental crisis. Then the other thing I just wanted to touch on is the fact that in this tight urban environment, we still need to be able to give people the fresh air and the facilities they need. But also we don't have the space to do anything other than to be right in the high street with others. So how did we set about dealing with this? First of all, we tried to blur the boundary by the creation of place. And we created activities inside the building where people will be able to go in and come out of without that feeling of going into a mental health inpatient block. You might be going in there to use the cafe, you might be going into there to use the shared gym and sports hall and meeting rooms for the local people. Likewise, there's a sort of boulevard to invite people in to use some of those facilities in that additional public realm. So we're blurring the boundary. The other thing is we've taken the opportunity to do some education with the local folk in terms of engagement with the residents and community, correcting those misconceptions and myths associated with mental illness. So throughout the planning process, it's been very much engaging with local residents and community to get that relationship and to see what they would like out of the process as well. Thirdly, there is that bit about service users, carers and staff. We want our staff to work in a place that they feel proud of and that they're not hidden away somewhere that they can point to and say, that's where I work. Likewise, our work with service users and carers is very much that promoting recovery and well-being that you heard described in the lectures earlier. The tightness of the environment does mean that we are after a multi-story solution. So we're looking at staggered terraces, vertical landscapes, roof gardens, green walls, everything that tries to bring what would actually be a rural garden outside into the confines of the most densely populated borough in London. So that's very important too for the well-being, outside, fresh air, greenscape, even in this urban environment. But it also breaks down the boundary. Now that's actually not an existing view of our new hospital site, because the existing view shows that completely flattened and some bricks as it's being built. But the key thing that I want to take from this slide is that this is actually quite a main road that this is on, and there is no hiding place for this building. It is right there at the edge of the road. There's no walls in front of it, and there we can interact fully. What it will look like, and I bring you to this next slide, is just again, look at the design, look at the fact that there isn't that wall, the fact that you can sit underneath the overhang in the right-hand side. You don't need to go in, you can just be passing by. You can be passing by to use the cafe and other facilities and to be walking from one site to another nearby. Again, have a look at that transformation of place. Have a look at that building as far as we're concerned. If you're a staff member, you're going to be proud to work there. If you're referred there as a patient now, you know that you are going to be in good hands and that somebody cares about your mental health as much as they do your physical health. And that to us is very much the destigmatization by architecture. I'll be answering questions. Thank you very much.
That was very easy to understand and of course very interesting to listen to. And I suppose that you have used then Lia's model as to use her toolkit. We could see that. has been a part of your work, right?
Absolutely. So one of the things that I think we did find very early on was that it's vital in mental health that you do co-design with your service users, with your patients. But one of the problem is they, the staff and the service users need to be educated about what's possible. Otherwise, they give you an answer which says, we'd like what we had 10 years ago, but we'd like it painted a different color. Yeah. And you need to be able to show people the art of the possible, what's out there, to raise their horizons. And that's what Leah did for us, was just people went, wow, that's fantastic about what's being done around the world. We could have some of that too.
And in what stage is it in right now?
So at the moment, it's flattened and there's some bricks going up. So that's essentially where that building is. So it's going to be another 18 months before it's opened.
Okay.
Of our program, we've got one building up and running at the moment.
That's very interesting. So I have a specific question to you, and it seems to be, I mean, if you compare to how we now treat it here in Sweden, a lot of small premises in Camden and Islington to the service user and to the neighborhood. And in Sweden, we have more focus to prioritize bigger or larger, bigger projects, so to speak, for to use that for more staffing and so on and so on. Is this a trend in London as well, to kind of get bigger units, would you say?
So I think there's two things. It's where you have something like inpatients, we're trying to bring our inpatients together, and actually one of the buildings that we're building is right next to another facility, so we're drawing those disparate units together. We have a lot of sites, yeah, we have over 30 and we're bringing them down to about 10, but we're putting them in transport nodes, so they're more accessible. But the other trend is that you have multi-occupancy of the buildings. So if you think about in mental health, the medical aspects of mental health are actually very small. Somebody's mental health condition is dependent on all sorts of things. You might be in crisis because of, I don't know, housing, your tenancy, debt, all those sorts of things. So what we're looking to do is we're looking to bring a facility where we can bring, it's local, but we can bring the voluntary sector with us. And likewise for our service users, physical health is important. So we want to be able to bring physical health there too. So it's this sort of multidisciplinary aspect of mental health is important to us.
Yeah, I think so. And even during this time, during this past year and the pandemic, I think we will see more of this coming up, and it will increase, of course, a lot. And another question I have to you is when you think about the management team and the staff around the UK, are they really as brave as you say? And are they really brave to handle this more of open public premises rather than they used to have? What would you say? Are they mature?
I think mental health is going further up the agenda. I think the idea that 1 in 5 of us will have a mental health condition at some time in our lives is really important. That message is getting through in the UK, and there's more interest. I think in terms of some staff, some service users, again, any change is difficult, and you have concerns about security or 150 different things. But on the other hand, we're not the only sector that's gone through this. If you walk into a bank compared with 10 years ago, and there's still some security, walk into other areas which have come that way. So we're like every other sector in that sense, but the momentum is there for change. But we have to address individuals' concerns, as we go along.
Thank you, Malcolm. Okay, thank you. So for this now, for the panel, and now I will see if we have any questions from our chat. If we could see anything, and I will ask my colleague here if we have one question here, and that is for Cristiana. Now we're talking about the UK and Sweden, and are there any strategies, Cristiana, and learnings that you will take with you from Sweden when designing this new Cambridge Children's Hospital, Cristiana?
Yeah, we we have just been appointed 1 month ago, more or less. We are just starting up. The design team is composed by us and Hawkins Brown together with Turner and Towles and Bramble, MJ Medical. It's a very competent team. We have all of us quite a lot of experience of both mental health and pediatric environment. But I would say the Cambridge Children's is the first project where I really see an holistic care model as the ground of the project. The ambition is to take care of the whole child, mental and physical health within the same building, not only co-located, but also integrated. So we are going to bring with us the knowledge on how to design healing environment. My ambition, or our ambition maybe, is to answer to the holistic care model with holistic and universal design, to be able to address both mental and physical needs and small children as well as teenagers with a good balance. But we are just starting now. And this project will require a very new way of looking at the built environment, because it hasn't been done anywhere else in this scale. So I'm very thrilled and excited.
Yeah, I think so. And I think it's fantastic that we are there. But I think also there is something when you talk about Borås, maybe, and Cambridge as well, and that's about the entrance hall, because I remember when you talked about Borås as well. So to have this big entrance hall that could be shared between, more public accessible and could be shared among different kinds of patients. Is that something that will be the same in Cambridge, do you think?
Absolutely. We want to work this way to have as much as possible shared spaces that have this feel of welcoming and healing atmosphere, shared spaces by different patients, shared spaces by parents as well as staff, because the integration is actually the main idea of the project. Integration of mental and physical health, as well as integration of research and healthcare. So we will have to work. We are talking about these spaces for integration, and this is something that when I see it in front of me, I think the entrance hall of Borås is an inspiration for that. What we will have to design.
Yeah, and I think I also believe very much, as I said in the beginning, the architecture is a lot about making, not what it looks like. And then going back to you again, Leah, to see more, you were talking again about this when we talked about challenging architecture. And I think also that a building is a building, but it's also its context. It means that it's part of a bigger plan in the city. And it's a dense area as in London, or more outskirts as it would be maybe in Borås. It's still something what it shows up to the public and be public accessible and kind of, be welcoming. And when you think about more of, if we can go back, Leah, to challenging architecture a bit more, because I think this is really interesting. Could you just say something more about that?
I think, and that different nations and different people perceive mental illness differently, and they have different health systems. So it's very difficult to compare. I mean, different staffing levels, different approaches, different notion of stigma. What is stigma in London is not necessarily the same stigma in France. The same thing is, so there are a lot of cultural aspects that are projected in buildings, and a lot of social aspects. So I think a building is also a social artifact, because it creates the society of people who live and interact with it, but also the society influences the building. So it's something that it's very much embedded in the culture. So in that sense, for me, it was a surprise to see what other people have done with their buildings, because it's very different, but I cannot judge them, because I would have to do research in their context to see what this means, to see what this means for their patients. And a lot of these buildings, I've never done research, so I cannot really judge, but I think we shouldn't judge. because we cannot know how it is their culture, how it is their perception, how it is their functions. But I think it's important that we see more and more things that are different and they don't look like hospitalization. Some of them would not be successful. Obviously, some of them might be very successful. My research in awarded buildings shows that sometimes innovation can be a little bit bad thing, but it's necessary. But it can be also a marvelous thing. But the only difference between the two, if architecture can harm, even with awarded buildings, so I don't believe anymore to awards, is if the patients have been involved. Because I think that's the baseline, that patients need to be involved.
Yeah, I think you're absolutely right. And of course, you are a researcher and you think about it that way. But if I then ask Cristiana, being a practitioner and architect, how have you been? Are you now using research to see some of the lessons learned, for instance, in Borås, that see those rooms that could be more experimental? What you said, you're using wood, or if it will be painted or faked or whatever the materials, as you are very interested in the interface, Cristiana, between research and our practice work. Are you going to follow up this by doing some research afterwards, Cristiana?
Yeah, we have some of the questions in the chat are also around this post-occupational evaluation. So I think it is a major issue that I would like to take it the occasion of this webinar also to lift this question. There is too little research on building environment and the effect of the building environment into the healthcare. In Borås, for example, we have been laying on the research bed at Trondheim that has looked at the effect of wood interior on patients in a very specific situation. It's actually a very interesting research, but we would like to make it on a larger scale in Borås. But the question of research from the effect of building environment into patients is not really prioritized by healthcare organizations, because of course when they enter this building now, they will be researching about how the patient-centered model of care works, how the collaboration works between the different units, how the effect of putting together outpatient and inpatient care works. So they are much more interested in the organizational and service aspects of this transformation than to look at the building in itself. Okay. We have tried to raise the question on looking at them. And I suppose we are going to do something. And also I want to say something more about this. In Sweden, we haven't yet developed model to evaluate the building, the architecture after the project is finished. There isn't any model that is applicable to all projects. And this is something that we discuss quite a lot at Chalmers Center for Healthcare Architecture, because every region, every trust is interested in that model and how to develop that, not to become too bureaucratic, but still you want to have that answers. Was it worth to invest all this money? Did it make a difference?
Yeah, I think also when you listen to when we watched the film from Stefan and Jan, I think when Jan said that you could kind of reduce the days that you would stay into the care with I don't know how many percent, that is really one of the best evidence, of course, when we talk about this. And I mean, when I can think about the book that and all the work that Stefan has been doing with Borås, for instance, and Esther as well, when you talk about daylight. You haven't spoke so much about that today. And that's something that we are for us here in Sweden, daylight is extremely important. And could you say something about that as well, Cristiana?
Yeah, daylight has been, of course, it is a challenge as well, because it's you want to have solutions that are quite compact and easy to orientate within. At the same time as you want the daylight to be in the building as much as possible. We have taken help of simulations quite a lot. There are so very good tools today with digital design on how to improve daylight exposure within the rooms. And I would say it is a challenge in healthcare buildings to work with daylight to to a very good level, because at the same time, really, you want to work with space efficiency, good overlooking from the staff to the patients, etc., and how to do that. In this project, we took help of very much of simulation systems, simulations models. We, for example, modeled the skylights, the lanternines in the entrance hall to make them very effectful in the shape and in the size, as well as energy efficient. So there are many, many aspects to take care of.
Okay, then I would be interesting to hear more from Malcolm, actually, because then there is a question about this, and this is about research and how you, Malcolm, believe that research lays ground for this field that is sort of capable of adapting these new challenges, as you talked about this, and that will arise sort of in the society, and also how this will affect mental health in the long run. Do you have any idea around that, Malcolm?
Yeah, I was actually going to reflect as well as what Cristiana was talking about in terms of the difficulty in research and getting actually the purest of the architectural effect to be understood, because people are always looking for other sort of clinical research to be added in. But I think it is undoubtedly, there is that piece of a good therapeutic environment we know improves the quality of care, we know reduces, as you were saying in the video, the length of stay, and therefore people's need to be within those facilities. So actually turning that into a piece of research says it's 1.32 days or something is going to be very difficult, because essentially I suppose you'd have to build 2 buildings, one of which wasn't good and one which was. I think in the wider sense, though, in terms of how you create this, I don't know, virtuous loop that says better design, better buildings gives you better outcomes, and that becomes better accepted, I think is probably the best we're doing in terms of research. That undoubtedly is going to be done through things like direct patient safety measures in terms of mental health, actually how service users patients are on wards, how intense your supervision from nursing, staffing, and those sorts of aspects need to be. So if you have a calm, therapeutic environment, you actually probably need less staff, you have fewer incidents, you have less tension in the environment. So that is a good thing. So it is these indirect qualitative outcomes which essentially will give.
Hello?
We lost Malcolm, I think.
Okay, but then a
the
very short
feedback into the benefits of having that therapy.
Yeah. Thank you, Malcolm. And then I think it's one question then for you, Leah. What is your experience on this so-called POE, post-occupancy evaluation, meaning what afterwards, what have you evaluated, Leah?
Yes, but I think it's also a very vague term. I mean, as a researcher, any research is in a sense a post-occupancy evaluation. But, and of course it's more effective even if you know what you are looking, but I'm also skeptical sometimes for what people mean by a POE. Sometimes we see, I have seen POEs who is just checking that there is no leakage in the building and things like that. So, and things that are important from a project management perspective, but not from a therapeutic perspective. So I think this is what it is important to know what we are looking, to find a way to find it, which is, I mean, we have tools, but, and this is what I'm teaching also at the MSc, my students, how to do that. But I have seen also a lot of POEs that are just unnecessary, not unnecessary, but irrelevant to the therapeutic role of a building. They are relevant to the builders, but not relevant to the patient.
Yeah.
Okay. Good. Thank you, Leah. Thank you very much. Well, now I have a question to all of you that would sort of, summarize what you have been talking about, or maybe not just summarizing, but also to see if you would look into the future. And that is a question. If you think about the future, what kind of mental health care do you see when you look into the future? And I will start with you, Cristiana.
Yeah, that is a very difficult question. When it comes to what I said before, I really dream on starting to talk about mind or soul and body again. I think we have lost that for the last 200 years or maybe more. Hospitals, mental health institutions are being placed outside of the city, isolated. Now we're bringing them back into the city, close to hospitals. Maybe in the future, it's going to be much more integration, and that's something that I really hope and look for. And on the other hand, to work, of course, as architects and planner, to work with mental health before patients get sick. Design the cities, design our housing, design schools to prevent mental health, to become so sick that you have to look for help in the hospital. So this is a responsibility I always tell to all my students. Even if you are not going to design hospitals, you have to design cities and buildings that support and enhance health in general.
Thank you, Cristiana. And then Malcolm, when you look into the future, what would you like to see that you don't know today? What we are not doing today, actually.
Okay, so there's certain things, but what I really share is the fact that I think in the future, the destigmatization of mental health will mean particularly it will come out of what are viewed as far away establishments which are behind walls. It will become more like physical health. It will become mainstream. It will become integrated. It will become holistic. It will become localized. And that's what I would like to see in the future of mental health.
Thank you. And then Lia, what do you think about the future?
In order to think about the future, as a researcher, I have to think back. And I remember some of the patients in my interviews during my PhD years, which is more than 20 years ago now. They told me, but this needs to be a hospital, because if it is a hospital, it can become well. However, because I was asking, would you like a building to look like a hospital or like a home? And they said, but I have a home. If this is a home, I'm stuck here forever. And I think this idea of integration and possibly my hope would be, because the problem with mental illness is that we don't have very accurate diagnostic tools and we don't have very accurate treatments, like medical treatments, that we can reach in that point soon, like we have reached for other conditions. And we can sort of like normalize mental health, like anything you go to your GP and treat it as anything else. Maybe just go to the pharmacy and take something and treat you like I have myopia and I wear my contact lenses and I'm treated. So that's what I would like to see and hope.
Thank you, Lia. And I believe then very much that if we start to talk about mental illness as something that is very much a part of our daily life, because when you talk around families, friends, at work, or wherever you are, there's always somebody who don't feel so well. And I think especially now after this year, after COVID, there will be an increase in mental illnesses, and also that all kind of only just open daycare facilities maybe, and of course healthcare, big projects such as hospitals will be part of this. And I think this is something that we should all start to talk about more open and more friendly. So that is also part of to destigmatizing mental health, to start with yourself, being us, and also to how we can talk about this. So I just want to say that This has been such an interesting hour for me, at least, to listen to you. And I hope you all out listeners and participants also felt that this has been quite an interesting hour. And of course, there is so much more to discuss. We can't just, now we were trying to highlight this and also lessons learned from the UK and from Sweden. And I think it's this collaboration between countries is just as important as just look at one project. And we also know that these kind of projects takes a long time. So for instance, when Cristiana won the psychiatric hospital in Borås, that was like almost 10 years ago. So a lot of things could happen during that time, which is also quite, of course, quite interesting. But most of all, I would like to thank you all that you have shared now your thoughts and knowledge together with us, and also that if we are going in to rethink and why this is important, we also need to give that message to politicians, to decision makers, and of course the staff, as we have talked to that today. And we all need to have a focus on being more human and to have focus on the patient. So there is a lot more to discuss, and I hope that you will then be able to follow us, and we will be able to follow up this afterwards. And there will also be some contacts, and we will show that at the end of this seminar. And then you know that you can contact White, of course. We have been hosting this webinar, so you will get our address. And then I just want to thank you all, our panelists, Malcolm, Lia and Cristiana, and of course, Stefan and Jan, for sharing this with us. And it has been a most interesting hour, and I hope we can get back to you another time. Thank you very much. Bye-bye.